Good evening and welcome to Doctors on Call. Tonight we're talking about the diagnosis of strokes and other neurologic problems. I'm Dr. Ray Christensen from the Department of Family Medicine and Community Health at the University of Minnesota Medical School here in Duluth, and I'm your host for tonight's program. We'll be taking your calls about everything from Alzheimer's disease and MS to chronic migraines and strokes. Just give us a call at 218-788-2844 or toll free at 1-877-307-8762. And here to answer your questions are tonight's panelists. Dr. Dimitrios Giannakidis, a neurologist with Essentia Health-Duluth Clinic. Dr. Samuel Laney, a physical medicine rehabilitation specialist with St. Luke's Physical Medicine and Rehab in Duluth. And Dr. Jake Prunuske, a family physician with Lake Superior Community Health Center in Superior and a faculty member in the Department of Family Medicine, Community Health at the Medical School in Duluth. Our medical students answering the phones tonight are all from Minnesota: Anthony Hacker from Alexandria, Marley Novak of Perham, and Courtney Tussler from Brainerd. And now on to tonight's program on stroke and other neurologic problems. Gentlemen, to start, we've got three different specialties represented here. So I think it'd probably be nice if we just kind of tell the audience a little bit about your specialty. And Jake, I think I'd start with you as a family physician, a little bit of your background and what family docs do.
Sure. So, I'm a family physician. Family physicians are a point of first contact for many people seeking health care. We provide continuity of care throughout a person's lifestyle, or throughout a person's life from birth to death. We can deal with most healthcare problems most of the time. And when a patient needs care that is beyond our scope of practice, we serve as a coordinator, helping to ensure that a patient who's receiving care from other providers or in other settings has that care coordinated in a way that keeps the patient's interests in mind.
Very good. Dr. Laney, you're a physical medicine rehabilitation specialist. Can you talk to us a little bit about what you do?
Okay. So physical medicine and rehabilitation sort of grew out of two issues. One was World War I, where a lot of people were maimed and hurt badly but didn't die. And there was an effort to try to restore them to maximum function. Also from polio, where there were patterns of disability and paralysis, and an effort, it's the same thing, to try to restore those persons to function and understand the impact of their the things that polio had done to them. Since then, it's grown into a broad specialty with various emphasis. Some people do a sort of a musculoskeletal or sports medicine or injection-based pain medicine type of PM&R. Others are more focused on neurologic rehab. I do what's called inpatient rehab. There's hospitals within some hospitals that are dedicated to the rehabilitation of people who are perhaps too sick, weak to go directly home, but who are ready to do more therapy and more specialized therapy than can be provided in the regular hospital.
Thank you. Dr. Giannakidis, and I apologize when I don't get your name quite right. I'll keep working on it. Tell us a little bit about neurology and your background.
I'm a neurologist with special training in stroke, so I'm seeing patients anywhere along the way from the acute onset of stroke symptoms in the hospital until several months down the road, while working with these patients into finding what is hiding behind the stroke, what is causing the stroke, and trying to work it up and find the best ways in preventing new strokes, working along with a patient's primary care, family medicine doctor mainly at that in the post-stroke period.
Thank you very much, and it's interesting. The first question actually comes in about strokes. Dr. Prunuske, in your office, can you explain what some of the symptoms are of stroke? And maybe you need to go back even, what do I need to look for? When should I come and see you?
Sure. So we'll probably talk more about stroke in a little bit, I think, but symptoms that put my mind towards stroke are a focal weakness or a focal loss of function. So one arm or one leg or one side of the body not working, perhaps a droopy cheek or an inability to speak are very common symptoms of stroke. Stroke can have lots of different manifestations or lots of different ways of looking depending on where in the brain the stroke is coming from. But for most folks, most of the time, stroke presents with a sudden onset of either paralysis or sensory changes or inability to speak.
Anything that either of you want to add to that?
So an easy way for people to remember and is what we tell them to think and act fast. Fast is
Thank you.
face, if anything looks different on their face, especially when we talk about asymmetry, right and left side looking different. That's something that they need to look into, like a red flag. A stands for arm, because when they cannot lift their arm. S stands for sensation, if anything feels different. Again, numbness or tingling, and T is for talking, when their speech is different.
So what is a stroke? Somebody, Dr. Laney, do you want to tell us what a stroke is, what happens?
So it's also sometimes called a cerebrovascular injury. It involves blood vessels in the brain. Broadly speaking, there are two types of strokes. There are ischemic strokes. Ischemia is lack of oxygen and nutrients that the blood would normally bring to the affected part of the brain. There are also hemorrhagic strokes. Those are bleeds. That's the two distinctions, and it's actually extremely important and part of what Dr. Giannakidis would be doing if he gets a call about a stroke patient would be early on trying to ascertain, is this a bleed or an ischemic stroke, because the treatment is very different.
The outcomes are different as well. Probably about 8 in 10 strokes or so are due to ischemia, and usually this is a blockage. You know, we have a clot or a blockage in one of the vessels. Sometimes clot will actually build up in an area of the brain and block off blood flow. And especially when they're found early, those can be managed quite successfully and actually oftentimes restore people to their previous function or nearly to their previous function. Hemorrhagic strokes or bleeding in the brain is a lot more challenging to manage, and we do have ways of treating them, but it's a lot more difficult in many respects than treating the more common type of stroke.
Yeah, nowadays we classify strokes based on what actually is causing them, what is that person's risk factors that eventually lead to a stroke. And there are a few big categories. The main one is a stroke that I tell my patients that comes from the heart, and the other kind of stroke that looks like more a heart attack, but in the brain. That's what I call the brain attack also, that comes when a plaque is building up locally, either in the carotids, which are the main blood vessels that bring blood to the brain, or in the arteries inside the brain. So those arteries block off because that plaque is building up, and the result is the stroke. The first category from the heart is when a clot is being sent from the heart to the brain, and wherever it stops, which could be completely random, then that is the stroke, and the symptoms the person experiences depend on the area where actually the stroke is.
So then let's go back just for a minute, because I don't want to forget this. Dr. Prunuske, you're the family doc here, or any one of you, what can we do to help ourselves prevent a stroke?
Sure.
What are the biggies?
Preventing a stroke is actually really easy in theory and hard for all of us to do. Maintaining a healthy lifestyle. So probably the single most important thing might be not smoking, or if you do smoke, quit. Followed by controlling blood pressure if you have high blood pressure. Making sure you maintain a healthy weight and eat things that grow on trees or grow in the ground. And those things can go very, very, very far toward preventing stroke. In people who have more risk than an average person, sometimes medications can help. So taking a baby aspirin once a day, particularly in middle-aged and older women, can be very helpful in preventing stroke. And in people who have diabetes or other things which increase your risk for stroke, controlling those conditions as well can be very helpful.
Dr. Laney, you were going to say something earlier, and I kind of, I think, cut you off a
Oh,
bit.
Dr. Giannakidis was speaking about embolic strokes from the heart, and I was thinking that is one of the biggest reasons that many people with atrial fibrillation are on blood thinners, because probably the biggest single category of strokes we see are embolic, went up the carotids, hit middle cerebral artery. That's the single biggest category that we're working with.
So we talked a little earlier. I practice in Moose Lake, and there's a lot of us that live out in rural northern Wisconsin, northern Minnesota, northern Michigan, probably southern Canada. We've done a lot of work in the state of Minnesota on stroke preparedness. And we were talking earlier, Dr. Giannakidis, maybe you want to talk about this, about stroke-ready hospitals, and you fellows both work at a stroke center.
Correct.
What's the language on that?
The hospitals are designated as primary stroke centers by the Joint Commission, which is a national, actually follows national standards. And this actually means that we are in the position to treat acute stroke patients and actually receive patients that were treated elsewhere for further care and a complete thorough workup. This is a big commitment for the hospital to run such a program, so they utilize a lot of resources. So that's why, in order to offer more complete and thorough care, we essentially try to centralize this process by having acute stroke-ready hospitals in the region that can actually accept patients closer to home, and then we receive the patients afterwards to continue their care.
I want to follow up on that, though. I think it's important that people in the community don't, if they think they're having a stroke, they shouldn't try to find where a stroke center is and try to figure out how to get there. The most important thing is just to call 911.
Exactly.
And when should they do that? Because that was my next question.
Yeah, the stroke management, the sooner it's identified and the sooner it's treated, the better the long-term health outcomes are for the people involved. And so I think anyone who's suspicious or concerned they might be having a stroke should dial 911 right away and let the paramedics, the healthcare team, the neurology experts guide where that treatment should happen.
Part of the training we offer to the region and the EMS providers is exactly this. So they take the patients to the closest hospital, not depending on the location of the patient, of course. So when there is an acute stroke-ready hospital, the patient goes there because they can receive the same level of acute care, stroke-related, and then they come to us. So the EMS providers actually have this training.
So for instance, an ischemic stroke that person might be a candidate for very strong blood thinning drugs, which the decision about whether to use those has to be made within about 4 hours. That can be started at an outside hospital. But that, as wonderful as that is, it comes with some risks. For instance, something like a 15% chance of conversion to some bleeding. Well, now you've got a different kind of stroke management. That's why they should come to a stroke center quickly, even if they initially presented and got the early part of the treatment at a regional hospital that isn't a stroke center.
Exactly. There are effective ways nowadays to treat an acute stroke as it is happening, as long as people arrive to the hospital early within a very narrow, though, time window, up to 4 hours and 30 minutes specifically, and then a few more hours if they want to receive more advanced therapies like pulling out the clot, for example. But then, since we deal with a very strong blood thinner, as you said, and the complications may be life-threatening, for the patient's benefit, these patients need to be treated in a higher level of care hospital, a hospital that is able to provide more advanced treatments in case of complications, which may reach up to 5% of the cases, in fact, with a complication that may be significant.
So we're kind of in the area now with stroke where we were with heart 30 years ago. So there's a potential that you can stop a stroke now and completely reverse it. Is that correct?
Yes, that's part of the...
And that's the reason to move quickly, fast, and then go fast.
Exactly, because we always need to remember that time is brain. So the more we delay, the more neurons or nerve cells actually we lose because of the lack of oxygen, the lack of nutrients to the brain, to that particular area.
So Dr. Laney, if someone does have the stroke, rehabilitation is very, very important. And I think acute rehabilitation is probably quite important also. Talk to us a little bit about what you do and where you fit into this picture now if someone has completed a stroke.
So once someone has, as you say, completed a stroke, then what? Maybe they're not moving an arm, et cetera. Maybe they're not swallowing effectively. They could be at risk for pneumonia. Maybe the bladder doesn't work. They could be at risk for bladder infections that could generalize to kidney infections. After the patient's had the stroke, they're very vulnerable to other things that aren't exactly the stroke, and that has to be managed carefully. What you'd like for the patient is that all they have to now deal with is that stroke rehab, not some other aspect of illness that came about. The other thing that I would point out is that an injured brain, whether it's a traumatic brain injury or a stroke, the injured brain seems to know that it's been injured. And the behavior of the neurons that are still alive, and there usually are actually quite a lot, even when it seems like a very severe stroke, the behavior of those neurons changes such that those neurons and nerve cells, they kind of beg each other to form new connections. This happens very avidly for about 3 months, and then it may taper off a bit, but it clearly keeps going for a year, and some people would say a year and a half. So there's an opportunity there to work with that stroke patient. And the term for these changes, a general term would be neuroplasticity. In acute rehab, we want to manage the patient safely and medically, and we want to get started on therapies to teach them useful patterns of recovery, whether it's walking or feeding themselves or working with the swallow, to take advantage of that window of neuroplasticity. And that has been shown to improve the outcome, the independence of the patient, the function of the patient, and even improve or decrease the cost that person later presents to the healthcare system.
One of the questions that has been asked and called in is dying from a stroke. Do most persons die from the stroke itself, or do they die from the physical and mental effects of the stroke later? And I'm not sure how to answer that one myself, and I'll just put it out there. Any one of the three of you might want to address that a little bit.
Currently, the stroke has dropped from the 4th cause of death in the US to the 5th cause of death, which has been a significant achievement in the stroke world. However, stroke is not something that will kill somebody directly. Usually people tend to die from secondary effects, an infection, or for example when they lay on the bed for a long time and they cannot move, or they may die from a clot in the legs or the lungs when they're not moving much. There are of course a lot of cases where a person may die from a stroke when the stroke is way too big, and with the swelling that comes after the stroke, the brain cannot accommodate it, and if we are not able to take any measures surgical in that case to reverse all that process, a person may die. And same way with the hemorrhagic stroke, when there is too much blood in the brain, in the skull cannot expand, cannot accommodate it, that person may die. So if somebody goes beyond that window and actually gets away with the stroke within the first week, when actually that's the period that somebody may die from a stroke, then usually they don't die directly from the stroke, but they may die from a secondary effect of it.
The leading cause of death in the country is heart disease, and the risk factors for stroke and the risk factor for heart disease are identical.
Exactly.
And so if a person has a stroke, they have a high likelihood of having heart problems as well. And heart disease does directly kill people all too commonly in this country. And so I think that's where your conversation about prevention earlier is so important. And I think also not just primary prevention, which means preventing it from ever happening, but also secondary prevention. So after a person's had a stroke, there are things that people can do to help make it less likely they'll have another stroke down the road.
Part of what we do as vascular neurologists is to deal with the stroke from the secondary prevention perspective. Usually people we encourage people to have a primary care doctor that they see regularly in order to take care of all their risk factors and address everything that may lead to stroke from a primary prevention perspective, meaning avoiding having a stroke, try not to have it at all. But if you have it, then this is where we come in, trying to fine-tune these little things that may decrease the chances of that happening again.
The other thing I'll add, sort of at the other end of this, is that for patients who have had a stroke, who later have issues related to that, rehabilitation doctors can serve as good resources to neurologists and primary care doctors about how to deal with things like spasticity that has occurred, in the late stages, or what we call late effects of strokes. The long-term management is of interest to neurologists and rehab docs as well.
At that time, we talk about quality of life as well. I think this is where the relationship of the patient with a rehab doctor actually helps, because having good quality of life helps overall recovery.
It's an area where the team of medicine, the teamwork that we do, and it's not just we as physicians, but everyone else that's involved. Why does a stroke cause a decrease in appetite? I don't have an answer for this one. I didn't know it did. So,
I would say the response of a person to a stroke is so variable, and I don't think there is a direct relationship. And we cannot say that the stroke in a particular area of the brain may lead to decreased appetite because there is any specific connection that is lost. But I think most likely this may have to do with mood disorders such as depression that come after a stroke, and some people's appetite as a result of depression may be decreased appetite, or some people actually have exactly the opposite. I've seen people with increased appetite. So I think it really has to do with mood disorders as a result of stroke.
Does an AV malformation increase the risk of a stroke?
Theoretically, yes, it does, but it leads to hemorrhagic stroke, which is when actually blood comes out of the artery into the brain by damaging the brain itself.
You would follow such a AV malformation, arteriovenous malformation, right? Because they change over time and the risk can change, right?
Yes, correct. Usually people find out that they have an AVM when that gives them symptoms. There are people that have that all their life and they never know about it because it never actually gave them any problem. So the main reason that brings them actually to our attention is a seizure, and secondarily is a bleeding and then we may find out they have an AVM, and there are specific treatments for that.
Jake, why would you experience a vision loss before a stroke?
Mm-hmm. So it's not that you have a vision loss before stroke. A vision loss is one of the first signs of the stroke itself. So as you block off blood flow either to the retina or the nerve that controls vision, you start to lose vision. Sometimes that blockage could be temporary and resolve. We call that a transient ischemic attack. But often even those transient things, if you look down the road with imaging in the head, there has been some permanent damage. So if someone has sudden vision loss, I would recommend that person call 911, because indeed it could be a first sign of a stroke that's happening right then and there.
So what's a transient ischemic attack? Can you open that up?
Yeah, so there's a bunch of different terms. There's transient ischemic attack, and then there's RIND, and then there's insults that have imaging findings later and ones that don't. They're all the same process, and it's just words that doctors use to describe sort of the permanence of the effects and the timing of the effects.
At this point, unfortunately, we lack a specific or good definition of TIA. However, I think this must be the most important message for whoever is watching us, that they shouldn't underestimate a TIA or whatever they consider a TIA, which people refer to as a mini stroke, because this is one of the most important risk factors of having another one. Actually, it's a sign that something is going to happen. So we encourage people to seek medical attention whenever they experience whatever thing is a TIA.
Yeah.
It seems clear that nervous tissue, brain tissue, can become dysfunctional and look like a completed stroke, perhaps before it's truly infarcted, which means dead. So there's a window of opportunity, if you present promptly, to perhaps let that come back.
And with that, great discussion tonight, great panel. I want to thank our panelists, Dr. Dimitrios Giannakidis, Dr. Samuel Laney, and Dr. Jake Prunuske, and our medical students, Anthony Hacker, Marley Novak, and Courtney Tussler. Doctors on Call is off for the next 2 weeks due to the holidays. Please join Dr. Alan Johns on the 7th of January for a program on diabetes, when his panelists will be Dr. Ryan Harden, Dr. Nahi Kabulai, and Dr. Jake Powell. Thank you for watching, and good night. Have a great holiday.